I just want to have a quick talk about the massive job that we do every single day in cleaning. So the total occupied floor area, it's 7 times that of Tesco's UK shop portfolio. It's massive. It's equivalent to us cleaning an area the size of Paris every 4 days. More people are sleeping in our beds than there are hotel rooms in London. We have over 40,000 whole-time equivalent cleaning staff. So we have more than that, but that's the whole-time equivalents. And that's 1 to every 3¼ beds. It's also the equivalent number of runners that run the London Marathon every year. So it's a massive task we're taking on every single year. And I just think it's always good to come back to that before we start looking at the past, the present, or the future. So let's really look at the past, the beginning, the first person that really brought on board cleaning standards for healthcare. You know, the first person to be an infection control champion was Florence Nightingale. Her research into hospital sanitary problems really paved the way for where we are today and where we're going in the future. So where have we been? It's been a massive journey. Essentially, in 2001, the first official national standards of healthcare cleanliness came about. And that was a big leap forward for healthcare cleaning. We know that things weren't going so great, but this brought the first standards. It published them, and they were published by NHS estates. We then, MPASA, updated those standards in 2007. And then in 2014, the European standards brought out a specification. The PAS 5748 doesn't really roll off the tongue, but we all know that's because that's the date is to do with the inception of the NHS. But they all had their part to play. In 2021, a group of experts within the healthcare industry came together to form updated national standards for healthcare cleanliness. It was a long time coming, from 2007 to 2021, but what this did do, is bring up totally new things. So we looked at the ethos for the document, what were we trying to achieve? So it was about collaboration, working really closely with our IPC colleagues, working closely with our FM partners, with our suppliers, with our estates colleagues and everybody else to ensure that we actually were keeping our environment clean. It was about transparency and assurance. So it's about actually showing, not trying to hide because we don't want the board to know that we're getting reds. We actually want to show them where our risks are and how important this is in preventing infection. Infection prevention and control, that kind of speaks for itself. It's about that supportive role. How do we work together with our IPC colleagues to ensure that we are reducing infection rates and keeping the environment safe and clean? One of the things that I always talk about here, I'm not sure if she's in the room today, but one of our colleagues who was working on these standards, Colette Sweeney, always talked about the fact that visual cleans are not enough, because we can visually say something's clean when it actually isn't. I'll talk a bit more about that in a while. And then, of course, continuous improvement, which I know sounds weird, because how can we continually improve? If we get to 100%, where is there left to go? But that comes back to the transparency and assurance. So some of the things 2021 standards brought in for you all was around our commitment to cleanliness. So it's talking about each organisation and their commitment from the board down to ensure a clean and safe environment. It also brought in the responsibility groups here very visually, because what we had in the past was schedules, cleaning schedules. So what we know is at 7 a.m, your cleaning operative arrives on the ward and they cannot do what's on the schedule because there's something else they need to do. So we've already set them up to fail. So what does the patient or staff need to know? They need to know that this area is cleaned once a day, twice a day, 3 times a day. They do not need to know a specific time. And therefore, this was created to ensure that we have that transparency again. Star ratings. Now, we know this is a bit of a Marmite issue. Some people love them, some people hate them. However, this was around transparency again. So it is around ensuring the public understands star ratings. Now, if you sat in, from the 2007 standards, a significant risk area where you needed to achieve 85%, and you were displaying that because that was part of the standards. So I'm a patient, I'm sat there, and I see 85%, which is a pass, but I'm sitting here thinking, am I sat in the bit that hasn't been cleaned? And that's not what we're saying. So a star rating system is much easier for the public and staff, to an extent, to understand. We also brought in the efficacy audit. So coming back to my point earlier, visual cleans do not show you everything. If I take a glass and spit in it and wipe it out, yes, people have heard this before, essentially you will pass it because visually it's clean, but it's not actually clean. We're not getting assurance. So this was the first step in doing that. So this was about looking at what are our processes? How do we clean? How are we using the right equipment? Are we using the right chemicals? Have the staff been trained correctly? So from that perspective, it was step one. We also brought in an updated cleaning manual that gave you posters and videos to help train your staff. We looked around the whole ethos of what we're trying to do here. So leadership, it's really key that leaders at board level are looking at cleaning and the risks associated with that. We need a high caliber workforce. We must train our workforce. That is so important. Training and qualifications, you know, looking at apprenticeships, sorry. The tools, we've got to give them, and I don't mean the equipment, I mean the actual sort of the toolbox talks, everything that we do on a daily basis. If you work in mental health, our patients going into an area where they have no idea of what's going on, what situation patients are in, they should be included as part of those ward talks in the morning to understand what's going on in areas. Equipment, obviously self-explanatory. Let's not build a hospital, buy 100 vacuum cleaners, and then forget that actually they have a lifespan. We've got to process that and put that into the equation. We need to start using professional language beyond the scope of cleaning, IPC risk, dirt, dust, debris. That's not professional. It doesn't show us what we need to know. Something's dusty, yes, but what kind of dust is it? So we need to start using professional language. And the power of partnership, and that's, I've already said about it, it's our IPC colleagues, our estates colleagues, our portering colleagues, our FM partners, our suppliers, everybody who has a hand in helping us clean our environment. So, this is where we are now. We've got the National Standards of Cleanliness 2025. What did that bring out on top of what we already had? So, essentially, it was around bringing the ambulance trusts on board. The idea with 2021 standards was always that every single healthcare colleague or healthcare setting would be working to the same standards. So the 2025 standards brought on board additional tools to support ambulance trusts in implementing the national standards of healthcare cleaning. So what does the future hold? And it's not all about robots. We have got some lovely robots out there, decontamination robots, but it's not just about that. So I'm going to talk a little bit, and I can't take credit for these slides. These are produced by ISS, but this is a project they've been working on for some time now, for about 2 years. So they're trying to identify how we clean at the right frequency. So different methods for different areas. Are we cleaning stuff? So since 2001, there hasn't been physical research done on why we clean things at that frequency. So this is looking at this, and it's about evidence-based cleaning. So since 2022, you can see there, I'm not going to read all that out to you because, I'm sure the slides will be shared afterwards, but essentially it is around, looking at the different touch points that are used within areas, bays, rooms, whether that's by patients or by staff, and how we can identify and reduce the bioburden created by that. So there is a lot of evidence, and we know this. We know the bioburden is increasing, the transmission of pathogens. We know there's an increase in a lot of different organisms within our healthcare sites. So there is things that have been identified through this project. The most frequently touched surfaces within a multi-occupancy bay. And it's not just, we've got visitors, we've got staff, we've got patients touching these areas. And one of the big takeaways is that we all think that everything kind of shuts down in the evening or at weekends, and actually that's not true. We're still seeing a lot of that activity at those times. So the next things are about identifying where we're going with these organisms and how we can translate that into a better frequency of clean. Sorry. As I said, these slides aren't quite mine, so. We also need to, we're working together with ISS, with HSE as well, and looking at the critical link between respiratory health and cleaning. So the other piece of research that we're working on is around using forensic methods in healthcare to identify how effective our cleaning is. So this is just, again, not one of my slides, but just to show you here. So we've got a commode there. Then you can see under the fluorescent light, so this is not UV light, it's fluorescent light. You can see the things that are not visible to the naked eye. So the idea here is we use a method of auditing that potentially could not only save time, but actually really identify where our risks are and where we're missing stuff, helping to train our staff as well. And that is potentially the future. There is a lot more stuff coming out, and I know many of you will have been involved within our new cleaning groups for the 2027 standards. So I'd like to, obviously, if anybody hasn't been involved but wants to be, please do contact us.